LVH progression, and there is actually a higher mortality when the hemoglobin is less than 10. Sometimes the patients cannot get it for whatever reason if they have like a severe allergy. It's very rare because remember, all of these medications are produced with DNA recombinant technology, so it's pretty much the same human molecule. But I have a patient who claims that every time I give it to her, she passes out, and I have to just follow her, and then whenever the hemoglobin is less than 7, I refer her for a transfusion, which is pretty suboptimal, but there's really nothing you can do there. Yeah. Okay, so if the MCV, one last review, if the MCV is high, so what do we do?
Check B12 and folate.
Exactly. The attending approach is you check vitamin B12 and folate. If it's an old person, you think about, if it's macrocytic and anemia, MDS. You think about MDS. Treatment of MDS, nothing. It's just expectant management. If the anemia is getting worse, then the oncologist can investigate. There's different types. Some of them are associated with cytopenias or thrombocytosis, and there are different treatments and different prognosis, but that's a separate topic. And again, MDS can be very, very indolent, or it can be very aggressive, and patients can actually die within 5 years. Okay, very good. And then you think about the other causes, liver disease. So cirrhosis can give you this, and hypothyroidism and drugs. And we talk about like some of the drugs. What are the drugs that you remember? We talk about 2 drugs. Which one?
Like antimalarials?
No. For macrocytosis, we talk about the HIV medication that we use to monitor compliance. ACT. Yeah, all of the medicines in that group can cause macrocytosis, and that's what ID doctors actually follow to ensure compliance with the regimen. And the other one is, it's an anticonvulsant, phenytoin, right?
Okay.
Phenytoin. So remember always that can cause also. And also, I think, just if you guys have a Hippocrates, look at INH. I think INH can also cause macrocytosis, if I'm not mistaken. INH, isoniazid, the anti-tuberculosis medicine. Yeah. So yeah, okay, so yeah, for your boards, guys, remember, they want to trick you with hemolytic anemias. You're pretty comfortable with hemolytic anemias. They're going to trick you with TTP. Just make sure you look for, always when you look at the blood counts, not just look at the hemoglobin, but look at the other cell lines, because that gives you more information. You're dealing with a more like probably more like a bone marrow process when you see cytopenias. You know, if you see thrombocytopenia, like the case I gave you. And if they give you the basophilic stippling, you think about, what was that, case 1, right? You think about heavy metals. Your heavy metals, because now they're giving you like more sophisticated. I want you to think about more sophisticated. Arsenic and lead can cause this type of pattern. Okay. Any questions for anemias? Any questions? Anything you guys can think of? Okay. All right. Let's talk about these lipidemias then. Did Ramiro send you the other one so you can pull it up?
Lipids,
Okay.
Yep.
Say it again?
The definition of anemia.
Definition of anemia? I didn't tell them, but it varies a lot. It depends on, from country to country, varies a lot, because a lot of like nutritional deficiencies, and it also is different from male to females, and also depends on the altitude where you live. So, but generally speaking, I don't know, I think for males it's anything less than 13.7 on the hemoglobin, and for females it's a little bit lower. I think it's like 12.5 I think. And it depends if you're pregnant. There is the dilutional effect in pregnancy. Anemia of pregnancy is very common. If they were going to do like a series of the 3rd trimester pregnant, they, like a lot of them will have anemia, and it has to do with dilutional, and it has to do with iron deficiency. That's why most pregnant females are taking some iron supplements. Yeah, the other thing, now that you bring that up, Dr. Menzo, is important. So in the inpatient setting, always look at the trends. Always look at the trends. You know, most EMR, most electronic health records in the hospital setting allow you to see like the historical values. So that's why you have to be detail oriented. You have to look at the hemoglobin trends, and you have to interpret those values in the clinical context. Meaning that if your patient is volume contracted, either got admitted with diarrhea, GI losses, whatever the case is, you're expected to see an increase in the hemoglobin. By the same token, if you have a volume overload patient, you're expected to see a dilutional effect, therefore a decrease in the hemoglobin. And you see this every time in clinical practice. If you're diuresing a patient, you start seeing that the hemoglobin actually goes up. And that's one of the reasons why we don't necessarily jump and start giving EPO to patients, because we want to wait and see in which direction the patient is going to move. I told you guys on the last talk that I gave you about diabetes, clinical judgment is very important. You need to develop clinical judgment. And how do you develop clinical judgment? Like having knowledge and trusting your decisions and being detail oriented. That's why you look at the trends. In my field, in nephrology, this is very true in nephrology. In a lot of the decisions that you make in internal medicine, we don't make them based on absolute values. We make them based on trends. Like for instance, in parathyroid hormone disease, we follow trends. We don't follow absolute values. In hemoglobins, you're gonna, and it's always important as an intern, you have to be vigilant. Like if you admit a patient and you see a drop, maybe dilutional, maybe that they typically tell you like, oh, up to 1 gram can be attributed to a dilutional effect. But you have to use your clinical judgment. If your patient got admitted with a GI bleed, you transfuse them, you're expected to see an increase of how much? 1 gram. And then you don't see such an increase, you can't really say that, oh, it's a dilutional. You need to use your judgment. You need to probably observe the patient maybe for an additional day before you release a patient with an active ongoing GI bleed. So yeah, that's why that's a good point, following the dilutional. Okay, so the management of hyperlipidemias, you guys probably know a lot about this topic and the medications that we use. What I'm gonna gear on this talk is not necessarily about the physiopath behind, but more like towards the available treatment options and what we do in clinical practice when we have patients with hyperlipidemia. This is bread and butter for primary care, so you have to be familiar. I'm going to try to emphasize on the combinations that are actually pretty standard of care and the combinations that you got to be cautious. Statins, as you know, they really, like I said about EPO in nephrology, statins really transformed the way we practice medicine, and it really made a humongous impact in the mortality rate, in cardiovascular mortality rate, and they continue to be the #1 choice. Another thing that's actually changing in clinical practice is that a lot of the statins are now available in generic formulations, so that also made it more widely available for different populations in the United States. But I also want to pinpoint about the need for follow-up of these patients. I don't know if if you've been taught in medical school, but like when I was finishing my training, they already were telling us that you don't have to necessarily follow LFTs routinely on these patients taking statins. I don't know if you guys are still doing it or not, but I don't think you can be blamed for doing that. But the most recent guideline, I believe that they recommend that you check LFTs at baseline, and if the patient don't have any symptoms, you don't have to keep following the LFTs. But generally speaking, when you read about the package insert, they recommend that you do a LFT check about 12 weeks after you initiate therapy, and if it's fine, you can continue to just follow the patients clinically. Statins are very powerful medications, and they also have very notorious interactions. I'm going to mention some of them because I want you guys to be familiar with these clinical interactions. One of the most serious side effects from statin is? Rhabdo. Okay, and which medication is associated with rhabdo? Which other combination medications are associated with rhabdo? Which antibiotic?
One of the mycins.
Sorry?
I can't
Macrolides, right? Macrolides. So, like, when I was in practice, actually, when I was doing my fellowship, one patient was admitted for, this woman had This woman was treated for dyslipidemia. That was her only medical problem, and she was diagnosed with H. pylori. And her physician actually started her on triple therapy for H. pylori. And the woman came in with one of the most severe cases of rhabdo I've ever seen. The lady was in fulminant, like renal failure. I mean, she didn't die, fortunately, but her calcium was tremendously low. You guys know with rhabdo patients become hypocalcemic? You guys remember?
Was it the effect of the kidney that caused
It actually sequestration, like a lot of like sequestration of calcium, and that's the reason why you don't aggressively replete it unless the patients are having EKG abnormalities. Because otherwise, if you start giving aggressively repleting the calcium, the patients are going to become hypercalcemic after the sequestration is being resolved. But rhabdo is a important clinical consideration. So every medication that can increase your risk of rhabdo, you always have to think about. So there is a commonly used blood pressure medicine that is prescribed that can be associated with rhabdo. You guys remember which one is that? Dr. Ben-Zur uses it a lot for rhythm disturbances. I'm giving you another hint. No, it's not amiodarone. Which one? Diltiazem, right. So diltiazem is one of those things like a lot of the rhabdomyolysis cases in the US are associated with simvastatin 80. I personally don't use simvastatin 80 for that reason, because a lot of the literature reports like simvastatin 80 is a dangerous medication when combined with some of the calcium channel blockers, even with amlodipine, can actually cause severe rhabdo. But it's still available. Some doctors prescribe simvastatin 80 because it's very cheap, but I don't go beyond 40 milligrams. Probably atorvastatin 80 is safer than simvastatin 80. Just make sure that you guys know that interaction. If you're prescribing DILT, the patients, they need to be educated, and the risk of worsening myopathy, and they have to inform you if that's the case. So there's another group of medicines, the transplant medications, the calcineurin inhibitors, that are also associated with increased risk of rhabdo. So generally speaking, transplant centers don't go beyond atorvastatin 40 when the patients are taking either cyclosporin or tacrolimus because of the increased risk of rhabdo. Some doctors, they prescribe atorvastatin 80, but make sure that you inform the patient. A lot of the times rhabdo can happen very suddenly, but a lot of the times it starts with the typical myopathy, and that can actually progress to a more severe form of rhabdomyolysis. So I have a slide here that I want to show you. Let me just move this. Oops. No. Can you center it real quick? Just need to see where to get. No. I don't know why it's not showing in the screen. Just go down. There's an algorithm here that I found in UpToDate that I want you guys to review it. It's about what to do when somebody has a statin-induced myopathy. Do you know why it's not showing here? Do I need to turn it on here? Or?
I can see it. I think it's just behind the window still. I can move it over more if you need.
It's just that it's very slow. This way.
Can you see it now?
Yeah, I can see it. Thank you. At the very end. Yeah, it's in the last page, I think. I put it in. Okay, very good. So you're going to see this a lot in clinical practice. The patients coming in with myopathy. That's not an absolute indication to discontinue and not to use it, because it's a very important agent, especially if you're treating secondary prevention, like somebody with established cardiovascular disease. You don't want to give up on these medications. They're very powerful and they're very effective. But most of the times you have to remember that the myopathy is a dose dependent, meaning that if you go down on the medication, you can actually improve it, or you can switch an alternative agent. So primarily we see a lot of myopathy mostly on Crestor is very powerful, but it also causes a little more myopathy. Atorvastatin can also is very powerful, that also causes a little more myopathy. Pravastatin is a water soluble statin. It's supposed to be better tolerated, but it's probably the weaker of the statins, and probably that's the last resort for those patients that are completely intolerant. But if your patient is having severe symptoms, your advice as a physician is like, you need to stop it, let's check a CK, and then you can establish the diagnosis. If the CK is not tremendously high or is not high, like rhabdo, usually when you guys think about rhabdo never happens if the CK is less than 5,000. You know, most doctors freak out. Like they see a CK of 700, say, oh my gosh, this number is very high. You don't have to necessarily freak out when you see a 700. You need to trend it, and you need to just, more importantly, you need to follow the patients clinically. And a lot of the times, you can have a coexisting primary myopathy, not necessarily just a statin myopathy, and that's a very complex group of diseases that can affect the skeletal muscles. And the diagnosis is very, it's actually done by muscle biopsy, and that needs to be followed and managed by a neurologist or a specialist in muscle. There's some rheumatologists that specialize in muscle diseases, but for the most part, neurology is the one that is mostly doing this type of management. So what I want you guys to think is like, it's not necessarily just the statin. It may be related. Yes, statins can actually worsen these symptoms, but it's not necessarily the cause. So another thing that you need to do is that you need to assess for other coexisting medical conditions. You need to assess for hypothyroidism. Remember the hypothyroid patients, they develop this proximal myopathy, and they're more prone to develop the statin-induced. And you also need to assess for vitamin D deficiency. How do you assess for vitamin D deficiency? You guys remember what is the test that you sent?
Vitamin D levels.
But which one? Because you can actually send a vitamin D 125 or a vitamin D 25. So remember the vitamin D, from the vitamin D synthesis primarily happen in the sterols in the skin are activated by the UV light. And then that's a precursor that goes to the liver to get one of the hydroxylations. And then the last hydroxylation happens in the kidney. Therefore, you end up developing the active vitamin D form, which is 125 hydroxy vitamin D. If you're screening for vitamin D deficiency, you order the vitamin D 25OH. That's the test, vitamin D 25OH. If you're looking for like if you're investigated for other causes of hypercalcemia or lymphoma or things like that, or granulomatous diseases, then you investigate for vitamin D 125. But for screening purposes, like if you just want to replace somebody with vitamin D, you do vitamin D 25OH. And how do you replace vitamin D? You guys know the different formulations that are available?
50,000 once a week.
That's the prescription. It's a plant-based precursor. It's called, the one that you're talking about is called Ergocalciferol. And you can either prescribe like 50,000 international units once a week for 12 weeks, or you can just tell the patients to take the other alternative, the other precursor, which is the cholecalciferol, which is the over-the-counter vitamin D. It comes in 1,000, 2,000, and 4,000 international units, and that's to be taken once a day. So when you're dealing with these patients, just make sure that you assess for that. But most of the time, most patients they're happy to continue if you educate them about the reason why we're doing it. Again, it's all about communication. Being an effective communicator. The reason why we're doing it, and then you can switch the statin to pravastatin, fluvastatin, or switching the patient to a non-statin medication. That would be the other alternative. And then at the end, you see that the algorithm actually keeps telling you try, and if they have a recurrence, discontinue. So don't just give up on it. The teaching point for you guys when you go home is don't give up on them unless you really have a very compelling reason. Remember when I was telling you guys about ACE inhibitors? You have to have a very compelling reason. Same thing with the statins, because we know that these medicines are strongly associated with a survival benefit, and you cannot just give up on them. Okay, so let's go up on the...
should be able to pull the, see the bar to the bottom there.
Which one?
Can you see it?
This one?
The, up a
gray
little
bar.
bit. the
Oh,
gray
it's this
bar.
one.
No,
Yeah.
Up.
This one is better, no? What do you want me to do? Just to go up? I can just do this one.
Yeah, there you go.
Uh-huh. Okay, so this is, you guys know that there's two things, like when we talk about hyperlipidemia, the primary prevention and secondary. These are the patients that are actually associated with secondary prevention are those with coronary disease, any type of ischemic coronary disease, strokes, anybody with peripheral artery disease. I told you guys, like in one of the lectures before you came in, that almost always these disorders coexist. Like you're not going to have somebody with just peripheral vascular disease. You know, you see peripheral vascular disease, you see renal atherosclerotic disease, you see like coronary atherosclerosis, and a lot of the times these patients end up, sooner or later, they end up developing some sort of ischemic brain disease. And then any patient that has multiple risk factors that confer a 10-year risk of cardiovascular disease greater than 20%, we call those patients secondary prevention. And there are different risk calculators that are available online. That's basically, these new guidelines came about 2 years ago, and there was a lot of like noise about physicians being unhappy with the way these new guidelines were proposed, because they were confusing. They're not pretty straightforward for the average clinician, and it was time consuming, and at the end it created a lot of confusion. But the key point for you guys is that you do one of the risk certification. The American Heart Association and the American College of Cardiology have their own, but there are others that you can actually look online, like the Framingham, and there's another one that is called the ACC. No, that's the A risk. I forget what the name is. The ACC cardiovascular risk tool assessment. Yeah. So, in another teaching point, the reason why I put it here is that CKD is an independent risk factor for having heart disease and dying from cardiovascular disease. I tell my patients just to point out how important it is. If they're having kidney disease, makes you likely to die from cardiovascular disease and not to die from renal disease. And the risk is significantly higher when the GFR falls below 30. Those patients, they have a lot of like inflammation and a lot of like inflammatory markers that are not clinically measurable, but they can confer an increased risk of cardiovascular disease. Okay, so going back to a different types of medications. Let me see what we have here. So we all know about the risk factors. I listed them there. Having a good HDL. How do you raise your HDL, guys? Yeah. Okay. Exercise. Okay, so these are the categories of treatment. I actually included one of the new monoclonal agents at the end. That Dr. Ben-Zur wanted to comment on that one. So we already got the statins. Let me just go down. And I listed some of the studies on Zetia, because there's more outcomes studies. Zetia is been in the market for quite some time. I would say probably like more than, I don't know, like 12, 13 years since it's been with us. But there was a lot of like studies showing there wasn't a lot of like benefit, but more recent studies have shown like some. I listed some of the studies here. Let me just get to that. Okay, rhabdo, I already told you. Oh, this is important for clinical practice. If you have a woman in reproductive age, you have to document that you talk to them about teratogenicity, or you have to refer them to get OCPs or some sort of contraception. Statins are highly teratogenic. At Oliveview, when I was working there was one of the clinic patients, one of the internal medicine clinic patients, they developed fetal malformations, and I remember one of the gynecology residents did an M&M. You know, you guys are not familiar with M&M, morbidity and mortality. When you're in residency, you always have like a once a month M&M case where they actually show a bad outcome. So I remember from that M&M that statins are highly teratogenic, and the law obligates you to document and refer these patients for contraception. Highly teratogenic, same as ACE inhibitor and ARBs. So we're using them very frequently in women in reproductive age. You have to, because this is a big source of malpractice. Okay, so the bile and acid sequestrants. You guys know, they prevent the reabsorption of bile acids from the small intestine, and we talk about it when we talk about diabetes, because that's one of the beneficial effects of these medications. They've been in use for many decades. They're safe. Most of the side effects are GI related. They're relatively weak agents, and we don't necessarily use them at first line, but I want you guys that they're there available if you need to. So we have cholestyramine, which is the most commonly used. So it's usually also used for pruritus associated with some sort of like biliary cholestasis, like primary biliary cirrhosis or some other cholestasis clinical scenarios. And one of the nice things about these medications is that it may be used with the statins, so you can use it in combination. In other words, one of the teaching points that I want you guys to take home is you can combine a lot of these medications, but always try to have some of the statins on board, even if it's in a little bit. Like you're gonna see some of Dr. Ben-Zur's patients like, oh, I'm taking it 5 milligrams every other day, and you're probably thinking like, why are you gonna give 5 milligrams every other day? That's nothing, but that's better than nothing. So that's why always one of the teaching points is just try to give something, a little bit of a statin. Okay, so this is the question. So niacin, it's beneficial, for lipid lowering, but the dose is much higher than when it's used as a vitamin. It's very effective, it's inexpensive, they sell it over the counter, and it's basically, the mechanism of action is thought to be basically increase the activity of the lipase, breaking down lipids. The problem with niacin is that it releases histamine, and one of the side effects, as you know, is flushing. So there's some strategies to avoid flushing, like some doctors recommend that you take aspirin along, or maybe you take the aspirin before you use the nystatin. Some other doctors, they recommend that they use it probably with food to avoid that. And you certainly don't use it if the patient has a history of recurring gout, because it can increase your risk of having gout. It's the beneficial effect for cardiovascular outcome is questionable, but it does increase the HDL levels, and that's probably one of the scenarios where you see patients still using it. You see I listed here GI distress, or you can take an NSAID associated. That is another strategy to minimize the flushing, or take it with meals. Okay, let me see. Okay, the fibrates. Fibrates are actually, there's several that you probably know, the gemfibrozil and the fenofibrate. Limitations to the use of these medications, they can cause elevated LFTs. So if you already have a problem with that, you have to be careful with these ones. And you have to be careful in the setting of advanced kidney disease. The manufacturer actually recommends that you don't use them when the GFR is less than 50, because they can accumulate, but generally I sometimes I let them go. I definitely not use them when the GFR is less than 30. But if you look at the black box, it says do not use it when the GFR is less than 30. And when the patient have like advanced liver disease also, you don't use them. They can in combination, they can still be used with statins, but you gotta be careful, because that combination can also increase your risk of rhabdomyolysis. So you can combine them, but you have to be more careful with this. So Zetia, it's, as you know, is a cholesterol absorption inhibitor. It's definitely, it also increases, mildly increases the HDL levels. It's one of the biggest clinical uses of Zetia is in combination with a statin drug, but the trials actually that I listed here, this is not the most accurate one. Rami didn't include the most. Yeah, let me pull it up really quick from my email. He didn't send you the most accurate one. How do I? This is the most accurate one. Yeah, he printed it for you guys.
Yeah.
Okay, so because I listed, I wanted you to know about the trial. So we have there was a trial called Improve It. It's the first large trial that was assessing like clinical outcomes with Zetia compared to a statin alone, and they found that actually after a follow-up of 6 years, these patients they have improved coronary cardiovascular outcomes, and the outcomes that they look was cardiovascular death, MI, hospital admission for unstable angina, coronary revascularization, and or strokes. So this is actually one of the most recent trials that I found when I was doing my reading about Zetia. So there is a clinical use. I know some doctors blow it off like, oh, that doesn't work. And one of the nice things about Zetia is that the cost is not very high, it's intermediate cost. And also that the side effects is usually well tolerated. Some doctors say it can also cause fatigue or it can cause myalgias, but it's definitely a more benign profile than the statins. And the teaching home for you guys is that more recent data is showing that it does have a cardiovascular benefit when they did a good quality randomized trial. And secondly, that is an adjuvant treatment along with the statins. Okay. And lastly, we have a new category. There are other types of medication, herbal, and other types of like estrogen. Estrogens were one of the. You guys are too young to remember this, but back in the 90s, there was a big noise about the benefits of estrogens, like hormonal replacement, and they thought it was going to be like the best discovery ever. For females, because they improve the lipid profile, improve actually the bone density profile of women taking hormonal replacement, but the trials actually were terminated prematurely because they realized that a lot of the women were coming up with like serious side effects from hormonal replacement therapy, including breast cancer, including heart attacks, and including strokes. So on your boards, you never want to answer the hormonal therapy. In fact, like doctors that are still using it routinely, I don't think those doctors are reading a lot of like literature about the data on these medications. But I'm mentioning that because in the past, or some doctors are still using estrogens to improve because it does work. It does reduce the LDL, but the risk of using this type of medication outweighs the benefit. So on your boards, always remember, hormonal replacement therapy is not standard of care in the US anymore. Okay, but we have a new group of medicine. They're called the PCSK9 inhibitors. I think the name of the one that is more commonly used, I can't really remember the name. I know the yeah, but I'm trying to remember the generic. Yes, can't remember that. Repatha. How do you pronounce it? Repatha?
Yeah,
Repatha. Okay. So I've never used it. Have you used it, Dr. Ben-Zur?
we use it a lot, yeah.
And how do you like it so far?
Tolerate about 80% of the time. 20% of the time people have like these viral flu-like symptoms.
Uh-huh.
And it's very dramatic at that time.
So it's an injectable medication. It's a monoclonal antibody. Some of these monoclonal antibodies can be associated with hypertension, so just make sure you follow blood pressure on these patients. But it's usually the side effects. When you look at the side effect profile, it's actually very, very benign compared to some of the other drugs. Most of the indications were associated with patients with some of the familial forms of hyperlipidemias where statins were not sufficient to attain therapeutic goals, but there is more and more increased role in those patients suffering from secondary cardiovascular prevention, like the patients that Dr. Ben-Zur take care. And the clinical studies I actually listed here. You have the second page, yeah. So I have like 2 open label trials. They were combined. There were like almost 5,000 patients completed 1 of 12 phase 2 or 3 trials with this medication, and they anywhere from 140 every 2 weeks or 420 milligrams monthly. The patients included patients taking statins, and 27% of the patients were taking high intensity statin regimens. And they noticed that the adverse events were very similar in both groups, so which is actually very promising. And serious side effects, the same, 7.5% in each group. and they have a much lower rate of cardiovascular events, like with with actually very good like rate hazard ratio reduction of 0.47. So it's actually pretty good. I have never used it. I figured like you guys were using it here because this is like kind of out of scope my practice, but that's the future of like hyperlipidemia management. And one of the promising things is that patients tolerate it. You know, you live in an era where when I went to medical school, the biologicals did not exist. As you guys know, biologicals are used now in many clinical scenarios. We use them as cancer anti-chemotherapeutic agents, Avastin. You guys know about these VEGF inhibitors. We're also using them as biologicals for management of severe rheumatologic disorders. You guys know about like Humira, Enbrel, and now we have like all these group of medications that are being used for Alzheimer's. They're coming up with amazing outcomes on these patients that are treated early in life, patients at risk of developing Alzheimer's disease, and now they're more and more commonly used in management of hyperlipidemia. So this is something you guys need to know because you will be using them in clinical practice. Yeah, I'm gonna start. I actually have a patient with severe hyperlipidemia. I'm gonna start him and I'll let you know how he does. But this is good to know that they're actually, you guys have good experience using this medication. Yeah. All right. Any questions? Any?
You have fish oil on here, omega-3s.
Fish oil. Fish oil is good for everyone.
Yeah.
It's a very harmless medication. The worst side effect is that you're gonna be burping fish the whole day. But I use it all the time because there's a lot of like data on glomerulonephritis, especially in IgA nephropathy with fish oil. And I use very high dose, like I use 6 grams. In the US, I think they used to have a prescription. They took it off or they switched it to a different name. It used to be called Omacor. Now I think they call it Lovasa, I believe. And it's beneficial, especially for hypertriglyceridemias, and especially as a coadjuvant for those patients that are, like I say, intolerant to some of the statins. So I typically, one of the side effects that you need to know that you may get tested on your boards is like if your patient is going to have major surgery, you're supposed to stop it because it can increase your risk of bleeding. So that's one of the supplements. When you guys review supplements, you need to know some of them because some of them can actually increase your risk of bleeding. Like ginkgo biloba is one of them, and fish oil is another one. And you need to know the ones that are associated with hepatotoxicity. I think one of the St. Joe's wort for depression, and there's some other herbal medications. There's a supplement on herbal. I'm gonna see if I can make like a little cheat sheet for you guys to review it because you get asked those questions on your boards.
So once we are in practice, do you recommend like 3 1,200 milligram pills of fish oil?
If primarily they have hypertriglyceridemia, yes, yeah, it works. And it's very benign, and usually they can just buy the Costco brand. There's a lot of like, if you go online, if you look for omega-3, I mean, they're gonna try to sell you like very expensive omega-3, but typically, yeah, I mean clinical practice, I see like, I tell my patients go to Costco and the same effect.
So you haven't noticed, I just had a patient today who said that his doctor was like, don't buy American omega-3s because they're bad, you have to buy like the Northridge.
Well, you have to think about several considerations. If they have religious, like if they're following religious guidelines, they need to buy the gelatin-free. So that one you can't find anywhere. You need to order it online very specifically. So you're going to see that in clinical practice. So, and you're going to see a lot of advertisement. A lot of this is false advertisement. Remember, FDA does not regulate any of the medications that fall into these supplements and vitamin category. So I can pretty much say that I can cure cancer with a supplement, and I'm not doing anything wrong. So there are a lot of impurities in this. She may be right in some aspects, because if you look at the arsenic exposure in the United States, we get arsenic. There's 2 forms of arsenic exposure in the US. One is the organic and the non-organic. Like the one that we get with food is not the dangerous one, is not the one that increases your risk of malignancy. But a lot of them, they can actually come from using these supplements. So she may be right, you know. If you can afford like actually a very expensive fish oil that is associated with less exposure to any of these contaminants, why not? She has a point, but what I'm trying to say is that if you go online, it's going to be very confusing because they're going to try to sell you their fish oil. and they're not regulated by the FDA. That's why you see supplement, we cure prostate cancer. They can say whatever. Yeah. Okay.
What's the therapy for Alzheimer's, you said?
There is a monoclonal antibodies. I don't remember the name, but I'll send you the articles. Actually, what they're doing now, Dr. Ben-Zur, is that once you have the amyloid deposition, it's a specific monoclonal antibody targeting the amyloid protein, but once you have the amyloid deposition, there's nothing you can do. So what they're doing now is that 10% of the Alzheimer cases are associated with 2 genes, and then those patients that are positive for those 2 genes, they're being identified early in life, and they're getting treated in their 40s. They start treatment in their 40s, and there are some areas in the world that are highly associated with some form of familial Alzheimer's disease, like premature Alzheimer's disease. For those, they haven't been able to isolate the genes associated, but they're conducting trials right now with the use of these monoclonal antibodies. And like, for instance, we were talking about President Carter the other day. He got cured with a biologic. So these medications really transform the way we practice medicine. I'll send you the email with the name of these medications. I don't know if they're still in phase 3 and 4, but that's the future of Alzheimer's. The apolipoprotein E is also associated in developing Alzheimer's.
And maybe the presenilins.
Mm-hmm. My mom died from Alzheimer's, a terrible disease. It's terrible. Yeah. All right. Any questions, guys? Anything that you want to review? You're going on your test. You said pulmonary topics, or?
Yeah, I think eventually it'd be great to go over some
Yeah,
pulmonary
absolutely.
topics.
Anything that I can help you master your
I'll be
boards.
here for a while though. So
All right. Very good.
another month.
Actually, my brother is coming on Thursday. So we're gonna go out of town.
Okay. Sunday.
Um,
Email us. Email us.
I will email you.
Okay.
Thank you.